is Derek Anane. I'm a senior editor for EClinical Medicine, and I'm very pleased to introduce Professor David Baker for this sponsored talk. I'm also equally pleased to be here in person for what's been a really engaging meeting so far and series of talks. Interesting. So, Professor Baker is currently based at the Blizzard Institute and has pioneered work on the symptomatic control of spasticity using cannabinoids, which has underpinned much of the current work on MS and cannabis. His more recent work has looked at translational neuroprotection and novel targets for MS therapy. As such, I'm sure we're all really excited to listen to his talk today, titled Targeting CNS Plasma Cells. And with that, I'd like to invite Professor David to the lecture.
Thank you, everybody, and thank the organisers for inviting me to present. I'm not really sure why, to some extent, because I don't have a lot of data, so this is actually going to be an interesting one. It's actually going to be more thoughts than data, but I will wake you up when the data slide arrives. So I've been asked to talk about targeting CNS B cells and plasma cells in multiple sclerosis, and I guess the question I put to you is this something we want to do? Because do we have the technology to answer this question? And my argument would be, yes, we do. So I think my disclosures, in contrast to Emma, who spoke this morning, I'm not a neurologist. I'm an immunologist, and in fact, I'll talk a lot about drugs, and as you are clinically qualified, you'll know a lot more about them than I do, and importantly, you'll be able to actually say the names of them much more better than I will be able to do. So my disclosures is that I made my own slides, so they don't come from any pharmaceutical company, and I guess I have to tell you that compounds in red are not approved for use in multiple sclerosis, and I guess we'll be seeing a lot of red because what I talked to you today about aren't really approved for multiple sclerosis. And I do have some, obviously, disclaimers, but I don't think they're really relevant to the content of this talk today. Now, what I will disclose is that I'm a member of the Bart's MS blog, and if you're interested in any of the slides, you don't need to take pictures. I actually put them all on the web there, so you can actually look at them at your leisure, so you don't have to take a picture of me. Okay. So we want to kind of learn about things, and I guess you've actually heard about all this morning, and so we'll actually go through a revision tour. And the first thing, of course, we need to understand is what are B cells and what are the B cell lineage. And it's actually more complicated than probably the T cell story to some extent. And if you work with animals, it's very, very different to what actually happens in humans. So I think in a lot of cases, animals can't really explain what's going on in humans because the drivers for the evolution of the human B cell is possibly different. But when a B cell is born from its stem cell, they become a different number of cell phenotypes depending on what they express. And first of all, they're essentially made in the bone marrow. And then what happens, particularly if you have a depletion, you start to see cells liberating from the bone marrow to start going in to fill the space. And generally that will happen is they will then start as immature cells, and they have lots of different names. Some people call them transitional cells. Other people call them immature cells. Some people call them regulatory cells just because they essentially produce interleukin 10. Now, as we know, interleukin 10 is a regulatory cell for T cells, but it's also a potent B cell growth factor. So one asks the question, of course, are they making IL-10 to inhibit T cells, or are they just making IL-10 to make B cells become more B cells? Now, the cells then will eventually start to migrate, and they'll change their phenotype, and then they go into the lymphoid tissue. So we have the spleen as the main site of genesis, as well as the lymph nodes. And then there's a choice. Now, When these mature B cells become activated, they may get stimulated by EBV, and then they will become memory B cells. And if they encounter antigen, then they've got two choices. One, they will drive into the memory B cell population, which is a heterogeneous population. So some of these have what we call immunoglobulin D on their surface. Some of them switch to make IgA, IgM, and IgG, and they're called the switch population, and they express markers CD19, CD27, and there's also a population that loses the CD27, and they're called the double negative population because they don't express IgD. So there's that population, and then there's the alternative route is that the cells become plasmablasts, which are kind of short-lived cells, and then they may become the plasma cell, which expresses a marker called CD138. Now, the genesis of the plasma cell is within the lymphoid follicles, and here they have a characteristic structure. So we have an area where the cells blast, and then they differentiate into the memory cells or the plasma cell lineage. Now, I guess historically, when I was kind of being told about these B cell follicles, we saw all these B cell follicles have lots of plasma cells in, and I was a bit surprised when I started to look at the histology. So here's a histology of deoxycytosine kinase. This is the enzyme that is involved in cladribine killing, and you can see there's two areas, the dark zone or the light zone, and you see there's lots of negative cells within the light zone, and that's where the plasma cells are generated. Now, when you look for plasma cells, and staying with CD138, what you'll notice actually in the follicles, there's very, very few plasma cells. So as soon as they're produced, they start to migrate out of the follicles. So looking for follicles in the CNS is not going to necessarily tell you everything about where the plasma cells may be lurking. And that's true also of the memory B cells. Now, the question is can we target these cells? And we can obviously use monoclonal. So we've got the rodent monoclonal, the chimeric, which is a bit rodent, a bit human, the humanized and the human. And for CD20, at the moment in green, this is approved for MS. You've got ocrelizumab and ofatumumab, but obviously we know that rituximab is used quite extensively. Nublituzumab is probably going to arrive. It's past its phase 3. So you're going to have lots of anti-CD20 antibodies that potentially can target. Now, we can then also ask questions, can we target other parts of the B cell lineage? And we can go for CD19. So this is CD20 plus a bit more on either side. So here you get some of the pro B cells and a bit more of the plasmablast population. And there's an antibody which isn't licensed for MS, but it's called blizumab, and it's been licensed for NMO. Now, the important thing here is this agent doesn't target T cells. Now, when you ask people how do anti-CD20s work, they say, well, it's because it's targeting the T cells. Yet, this is just as effective as anti-CD20. It doesn't target T cells. So it tells us that these antibodies are doing something more than just targeting T cells. Now, the question we ask ourselves is, can we actually target this population, the plasma cell population? And indeed, there are already licensed agents that target plasma cells. That's belantamab and indatuzumab. And these are agents that are used for multiple myeloma or lymphoma. So there are ways of targeting plasma cell biology if we choose to do that today. So the question I'm going to address is, do we have agents to target the plasma cell pool? And what do we want to see in the types of drugs that we have? So why are we interested in plasma cells? Well, that's because of what we heard this morning, is that you get, as a consequence of disease, you get a B cell niche formed within the central nervous system. So we have the production of oligoclonal bands, which is obviously a potential diagnostic feature in MS. But But we also can see that it's compartmentalized. So here you can see the serum versus the CNS. So obviously the B cells within the central nervous system are not necessarily the same as within the peripheral blood. Therefore, we need to think about how do we target the central nervous system? And I think that's the critical question. So what we know is that the oligoclonal band is very early in the disease. So at radio-isolated syndromes, you can pick oligoclonal bands. So it's a very, very early feature. Now, the question, of course, are the antibodies a chief driver of the mechanism of MS, or are they a consequence of the MS? And I think, yes, the only way to really address that is to get rid of them and see what happens. Now, the other thing I will say is I think we can definitively say oligoclonal bands are pathogenic. And the reason why we can say they're pathogenic is because we can transfer them into animals and we can actually see a pathogenic response occurring, I think, as was very elegantly shown this morning as well. So the question, of course, is it's not only the oligoclonal bands, but particularly in London, within Richard Reynolds' group, we found that, as we know already, is that within the lesions, you can see plasma cells, and then there's a suggestion of ectopic follicles forming, particularly in the sulci and maybe on the meninges. Now, these are very, very characteristic of actually most autoimmune diseases. So you have them in the joint, in arthritis, you have them in the kidney capsule within SLE, for example. So these are an example of B-cell follicle. I think in many cases it's just an aggregate of CD20 B cells. They don't really look like a follicle. But it's been suggested that if you have a positive follicle, that you are more likely to have progressive disease. So if you have follicles post-mortem, you tended to have a more rapid progression, suggesting that it may be an important target for progressive MS. And I think that's why we're potentially interested in it at the moment. Now, in terms of antibodies, what do we know about them? Well, I think this morning we heard a lot about them, so I don't really want to tell you too much because the expert has spoken. But clearly, there are antibodies within the central nervous system that can be seen within the lesions. And we can see activation of the membrane attack complex, which suggests that there is activation of the antibody pathway. We can also look for autoantibodies. And what we can do is we can just take the antibodies and see if they bind to central nervous system tissue antigens. And I think what has been found is that, yes, you can find antibodies to myelin. They're not 100% consistent. There is no single one antigen that has been consistent in every individual. And as also was reported, that many of the antibodies that are found and made are actually targeted to intracellular ubiquitous targets, suggesting that they may be secondary to the primary driver that drove the tissue damage. Then you get the liberation of neoantigens, allowing new antibodies to form. But importantly, we can show that there is pathogenicity. So you can take cultures and you can add the sera or concentrated antibodies from the CSF, and you can show that there's demyelination potential. And also you can inject them directly into the brains of animals and to see what happens. And so we've done that. I did have some videos, but it's quite unpleasant to see. So some of these antibodies actually induce symptomatic changes virtually instantaneously, as well as potentially driving effects in terms of myelination. Now, in terms of what we know that's important in MS is really the key experiment is the human clinical trial to some extent. And that tells us what's important and what's not important. And the fact that some people will benefit from plasma exchange has given us some confidence to some extent that there are people with pathogenic antibodies. Now, when people were looked and you were doing brain biopsies, and you were probably familiar that the pathology is being classed into 4 types of lesions, such as the pattern 1, which have mononuclear cells, pattern 2 of antibody and complement, and the pattern 3 are kind of oligodendrocyte damage. And it was suggested in some cases that the people who have the antibody in complement have a 100% response to plasma exchange, whereas those other people don't, suggesting there's some form of distinct disease profile going on. But that is just one example, and I would just say it was repeated and it wasn't reproduced. And so people with the pattern 1 were also showing some benefit from plasma exchange. So what I think is the important thing is probably these lesions are probably some form of sequencing that are probably common, because when you do the post-mortem of MS, it tends to be people with mononuclear cells and antibody in complement. But nevertheless, it tells us antibody is important. And I will say that obviously we think about them as being MS until we find the antigen. And I think it was elucidated this morning, is that actually maybe MS is a kind of syndrome of many, many different antigens, because obviously we had Devic's multiple sclerosis, which is now neuromyelitis optica, and I guess we've got myelin-associated glycoprotein, which has become its own disease entity to some extent, and maybe we'll start to see a few more as we find the targets. Now, the importance is whether they influence pathology to some extent. So the question, of course, is that when we look for the cerebrospinal fluid, we can't see any consistent antigenic target in all individuals. So the question is why? So this is a potential suggestion, maybe to start some discussion. I think what we do know is that whatever drives an attack, we have the cells coming from the outside in, and these form the perivascular lesions, which are associated with gadolinium enhancement, and the drivers for the inflammatory penumbra, where we can see mononuclear cells accumulating in the central nervous system and demyelination. Now, this perhaps conditions the CNS, but the important thing is our drivers and thoughts about how we treat MS is essentially stop the cells arriving and MS stops. But what we do know is that with time, you get sequestration of cells within the central nervous system, and this level of inflammation, which may be distinct from the inflammation that drives the attack, may be the underlying pathology that drives the slow worsening in advanced or progressive MS. And central to that, it seems that we have activated glia. So we have activated microglia that will activate astrocytes. Astrocytes will activate microglia, and they both can potentially be neurotoxic and glial toxic to the oligodendrocyte, perpetuating the damage. So the question is what does the B cell follicles do? So one suggestion, of course, is that they produce specific antibodies that bind to nervous tissue targets to cause a killing. But another suggestion that one of our postdocs came up with, well, maybe all it's doing is just producing lots of antibody, and by the actual interaction of antibody with the Fc receptors, you're actually creating an environment where you're just getting chronic low-grade activation of the glial cell response, and in the combination of a damaged environment, that may contribute to the environment damage that allows progressive worsening to occur. Now, the question, of course, is what happens when we do treatments, and I think the treatments that we've all tried a lot is anti-CD20, and we know that anti-CD20 is very good at stopping relapsing attacks, and we know it works very quickly. But what I would argue is that there's no really good evidence that that antibody is really causing a rapid depletion of B cells in the central nervous system. But we do see cases where we say, oh, well, B cells have disappeared. But that's generally when you actually sample 6 months after the initial trap. So if you got rid of disease, it's not surprising the cells disappear. We've also tried intrathecal antibody, and that just seemed to leak straight into the periphery, and it didn't, again, seem to have a marked effect on the B cells, but importantly, it didn't really appear to affect progression, and that was also the case of intraventricular use. Now, the important point I want to make here is that antibodies need to target cells, and they also need a depleting mechanism, so that they either need a complement or they need natural killer cells. Now, the question you say is, why is that important? Why do I have to say that? Well, it seems to me, as neurologists, you keep trying to do studies where you take antibodies and then try and treat CNS problems. Antilingo, good example, and I think Alzheimer's treatment would be another good example. So I think you're making it hard for yourself. Now, what do we know from the treatments? Well, the treatments that work in relapsing disease, they all seem to deplete memory B cells, and they essentially have the effect of reducing the memory B cell pool within the central nervous system. Now, of course, what does that mean for the plasma cell? Well, I'll go on to that, because obviously the first question we have to ask is, do any of the current DMTs actually target plasma cells? And this is the only bit of actual data you're going to see that I actually produced. So this is looking at the expression of different markers in different cell types. So we have here the naive cell, then we have the memory cell, then we have the plasmablast, and then we have a bone marrow plasma cell. So what you can see here, they express CD138, which is the really sort of plasma cell specific marker. Then we have this one, which is called B-cell maturation antigen. It's also highly specific for plasma cells and plasmablasts. Then you'll hear of this other one, Bruton tyrosine kinase. You can see actually it's present in most cells. But let's look at the targets for the different MS drugs. So anti-CD19, so that would be, that should be in red. You can see it disappears on plasma cells. Anti-CD20, high level on the naive B cells, high level on the memory cells, but it essentially disappears from the plasma cells. So the anti-CD20 is not really going to directly target the plasma cell. What about alemtuzumab? Well, actually, surprisingly enough, actually plasma cells express very little CD52, and therefore alemtuzumab shouldn't really target the plasma cells. What about deoxycytosine kinase? So that's the target from cladribine, and I showed you a picture of that in the lymph node, and you can see where the plasma cell area was. There wasn't much staining, and indeed, when you look at the bone marrow plasma cell, they actually don't tend to express much DCK, suggesting that they won't be particularly targeted via cladribine. What about sphingosine 1-phosphate? That's the target for fingolimod and siponimod and ozanimod and ponesimod. And again, it's interesting that the plasma cells don't seem to have a lot of the antigens, again suggesting that plasma cells aren't going to be particularly targeted. The interesting one perhaps may be natalizumab, that the plasma cells and the plasmablasts seem to have quite high levels. And obviously, that means it potentially can stop cells getting into the brain. But the question is, of course, what happens to the oligoclonal bands? And I think the jury is out. Some people say it works and gets rid of oligoclonal bands, and other people say it doesn't. But what does it suggest, of course, to me, is that most of these agents won't have any potential immediate effect on the plasmablast or the plasma cell population, and it probably doesn't have an immediate effect on the bone marrow plasma cells either. So what does that mean? Well, we know that protein therapeutics will have a poor CNS penetration anyway, and therefore they probably won't target the central nervous system. Cladribine is probably the only agent that probably gets in with a high enough concentration to really have an effect. But because the agents don't express the targets for these molecules, it suggests that we shouldn't have an effect on the plasma cells within the brain, and I think that's consistent with most of the data, is that most of these agents have a relative positive effect on the oligoclonal bands. Now, that's not to say it can't affect the oligoclonal bands, because probably what happens is you get some form of renewal from the periphery, so with time you may get a reduction. Cladribine, 10 years later, drop of about 50%. I think that's also the case with hematopoietic stem cell therapy. Now, of course, that has implications, and I think this is the good point, because now we're in the age of COVID-19. And of course, what I've just said is that I don't think it will work in terms of targeting the plasma cell to get rid of the oligoclonal bands, but it should mean, of course, that you will have a relative lack of effect on your childhood immunity. It should have a relative lack of effect on your vaccination response, and it should also then have a relative lack of effect on your COVID vaccination response. So that's why I think it's interesting when we think about the current DMTs. Now, just to show you that the data that I found is reproducible, I found it in another site, but plasma cells lose a lot of the targeting molecules, and we know, for example, that alemtuzumab does not remove child infection responses, and that the majority of people can make anti-drug responses within 1 month of alemtuzumab. So 85% of people make an anti-drug response within 1 month when you've got no T, no B cells. So it tells us that really it's not getting rid of the plasma cell pool at that point. Ocrelizumab, it doesn't remove pre-treatment condition infections, and that's also, it doesn't seem to, cladribine doesn't seem to inhibit the various cellular vaccine response. And some limited data suggests that the CD138 positive cells are not particularly depleted. And this would be consistent with perhaps what we're seeing with the vaccine responses. This is some work that was done by Emma and Ruth, and this is just looking at the COVID vaccine responses. And essentially, most of the DMTs don't inhibit the antibody response, therefore they're not particularly inhibiting the plasma response. The only two agents of concern are probably anti-CD20s, which we know will get rid of the precursors that will make the plasma cells. And the difficult one that we need to explain is, how does fingolimod have a problem? Now, of course, you can say that people get vaccinated when a long time after they've had the drug. But here's just an example of somebody who had alemtuzumab, who got infected probably during infusion. So they essentially had no T or B cells, yet they could make a SARS-CoV-2 antibody response, suggesting that alemtuzumab is not really going to target the plasma cell pool too much. Now, I think there are examples where we can get rid of the plasma cell pool, and that is ablative hematopoietic stem cell therapy. And the reason why I say that is because that is the only kind of condition where we have to revaccinate people, which suggests that the conditioning protocol gets rid of the bone marrow and the cells within the periphery, and therefore you get rid of the plasma cells and you need to revaccinate. Now, I think Mark Freeman would tell us that he uses cyclophosphamide, so he clears out the central nervous system, and cyclophosphamide does get in the central nervous system, but cyclophosphamide requires proliferating cells to kill. And I just need to tell you that in many cases, plasma cells are post-mitotic, so they're not dividing, and therefore they won't be susceptible to cyclophosphamide. And it's clear that there are a number of people that go through HSCT and the oligoclonal bands are not inhibited, suggesting that it's not targeting stuff within the central nervous system. And of course, there are people who still continue to progress. Now, does that say that the CNS is doing something different? Now, the question is, as I get to the last bit of my talk, is can we get rid of plasma cells from the central nervous system? And the answer, I think, is of course we can. And you probably know this better than I can, because you can treat it. And the plasma cell problem that you treat are things such as multiple myeloma and CNS lymphoma. So here are the agents that you already have at your disposal to get rid of plasma cells from the central nervous system if you so choose. So what I want to do is just give you a flavour of what they are and give you some rules of how I think you should select them. So I went onto the NHS site. This is the list it gave me: stem cell therapy, which we've covered. Chemotherapy, I'll ignore, because most of the chemotherapy agents are targeting proliferating cells. We have thalidomide-related compounds, proteasome inhibitors. Then we have a couple of monoclonal antibodies and something histone deacetylase inhibitor. Now, if you go onto the FDA site, of course, Americans have a lot more access to different agents. So they've got 45 approved agents or combination agents to target multiple myeloma. So what did I say? Well, I said agents should not be proliferation dependent because plasma cells are potentially post-mitotic. Agents should not augment the memory response. And importantly, agents should be CNS penetrant because the target is in the central nervous system. So if you're thinking about plasma cells, we can actually then look at different agents, and there are a number of monoclonal antibodies. Those are the B-cell maturation antigen. Then we have the anti-CD38, and then there's another monoclonal called anti-SLAM. So they could potentially be used for targeting plasma cells. The problem is because the target is not completely specific. So the things that are highly expressed on plasma cells are also expressed on epithelia. And the problem with this agent is it causes an ocular problem. Now, there is antibodies, and there is anti-CD38, and anti-CD38 targets plasma cells, plasmablasts, and the naive mature B cells. So remember, of course, antibodies would have a poor penetration, so I wouldn't suggest that these are important ways to go about it. And of course, what I would argue is you need that CNS penetrant targeting. Now, the question is, if you target plasma cells, naive B cells, I will say that it may not inhibit MS. And while you think about the example of why it may not inhibit MS, I'll tell you a way how you could avoid the CNS penetration element. And that is using kind of the big guns, which would be CAR-T therapy. So you take a CD8 cell, you expand it up, and then you essentially transfect it with an antibody binding site and a T cell signaling site. And this is called a chimeric antigen receptor. And this gives a new specificity to the T cells, so you can make it specific for CD19 or plasma cells. And of course, you can then infuse the T cells back. And because you have MS, they would then target into the central nervous system. So it would be an easy way of clearing out the central nervous system. And in fact, you could do that because actually you do have a BCMA CAR-T approved. And also there is a CD19 if you wanted to get rid of all your B cells. So the technology is there. The side effect is that when you give the T cells, you get a big cytokine storm response. And I think the main problem is it's kind of irreversible in many cases. So once you put them in, you've got never going to have a T cell ever again. So until you can regulate it, I think obviously it's dangerous for something that isn't life-threatening. But nevertheless, it shows you that it's possible to do that. Now, I'm going to now remind you about the agents that target naive cells as well as get rid of antibodies. And this is Tasicept, which you should have heard of. Now, the important thing is that these do not deplete or inhibit memory B cells, and they don't work in multiple sclerosis. And you may think about Tasicept making MS worse, but when you looked at the primary endpoint, this agent didn't have any effect. Likewise, getting rid of B-cell activating factor had no effect. Now, we've had other historic failures, and one of those is tumor necrosis factor. And as you know, that inhibits arthritis. Some people may suggest that actually it makes MS worse, but what I will just say is it doesn't stop MS. Now, the question, of course, is why? What is so different between MS and arthritis? Now, what we know is that in arthritis, you have ectopic follicles. But what is interesting is that when you look at anti-TNF, it will inhibit TNF in the joints, but it won't inhibit TNF within the central nervous system because the antigen or the antibody doesn't reach across the blood-brain barrier. And if you get TNF into the joints, it can get rid of the follicles. So you have a way of potentially targeting the follicles in the brain, but the question is would you dare use a CNS penetrant anti-TNF. Now, of course, you have the potential to do that. So if you go back to our multiple myeloma drugs, we have thalidomide and a couple of others. And you ask the question, how do they work? And you go, well, I'm not quite sure. But actually, they're very, very potent TNF inhibitors, and they're also CNS penetrant. In the list, you also have this molecule, which is a genus kinase inhibitor. And this one isn't particularly CNS penetrant, but there are variants that are CNS penetrant, and they inhibit TNF, and they can get in the central nervous system. And then there are other agents which do that. Phosphodiesterase inhibitors also inhibit TNF, and they can be CNS penetrant. One has been used in MS, which is called ibudilast. So the question, of course, is, have we done the experiment already? What happens to the oligoclonal bands? So I don't know, but there's a hypothesis. And then, of course, another set of agents we have are proteasome inhibitors, and there's a number of CNS penetrant ones. And finally, the agents which are probably most likely to reach the clinic first are the Bruton tyrosine kinase inhibitors, or BTK inhibitors. There are a number of them that are approved for B-cell lymphoma and B-cell leukemia. Tirabrutinib is actually approved in Japan for the treatment of CNS lymphoma. So you've got an agent that can potentially get rid of plasma cells within the brain. Now, BTK is expressed in plasma cells, not T cells, but also it's expressed on the microglia and the macrophages. And so this agent may inhibit macrophage function as well as B-cell signaling. Now, the action of the agent is largely to block B-cell differentiation, and we don't really know how good it is at actually targeting the plasma cell. You see that the immature cells have much higher levels. So, just to say, of course, that these agents are currently in trial for relapsing and progressive MS. So we've got the Merck compound, the Roche compound, Biogen compound, and the Sanofi compound, which is CNS penetrant. So we've got potential agents that would be useful. But just to say, and to kind of blow our trumpet, is that we have started to do a clinical trial of izazomib, and Wafa's up there, he will tell you about the trial. This is called Seismus, but the primary endpoint is to look at the proportion of people who lose oligoclonal bands following treatment. So it's a study of 70 patients. I believe the first safety part is completed, and we're going into the main trial. So I thank you for listening. Let's say that many agents are used as monotherapy or combination for antibody transformed cells. Many of them can be used for CNS targeting. I would say some of those antibody-producing cells are pathogenic, but of course we have to balance that. Are they regulatory? So there are these IL-10 producing plasma cells. So I would say the action of the in getting rid of antibody-producing cells is unexplored in MS. And so the question to you guys is it going to be a useful target? And in fact, we did actually do a scoping exercise where we looked at all these agents, and actually the neurologist considering, well, it wasn't that important. So it failed in the selection process. So I thank you for listening, and please be gentle because I'm not a clinician and I won't be able to answer many questions about the drugs, but I'm sure there's a guy who can answer those ones. So thank you.